start the meeting. Welcome everybody to our 156th meeting of the Board of Directors of Oxleas NHS Foundation Trust. Do we have any apologies for absence? Sally? I think Suzanne has sent me her apologies. Do we have any others?
Farid Jabbar.
There's not anything else. Are there any conflicts?
Sorry, Andy, I think we not have one from Sue Salter, I think, who couldn't make today?
We did, that's correct, yeah. Yes. Sue is doing her Poppy Day appeal work, which was moved because of the train strike, so we understand that. Any other apologies? If not, any declarations of interest? If not, we go on to the minutes of the last meeting and just go through for any points of accuracy. Page 1, if you go to sing out, because I'll be looking at the screen. Page 2, page 3, 4, 5, 6. Accept that as a record of the meeting, everybody. Yes, thank you. Any matters arising from there that you want to raise? On the board assurance framework, there's a lot in there. I'm not intending that we go through it in some detail because most of it meeting. But what I mean, Sally, could you, and I'm sorry I didn't mention this earlier, but could you just keep an eye as we go through to tick off the significant and highs to make sure we have covered it, and right at the end we just make sure that we have, and then go back to any matters we don't cover. I'm sure we will cover it, but nevertheless I do want to show that we've paid proper attention to the board assurance framework, because we have more significant risks there than I think we've had for some time. And as Stephen was saying earlier, and some of our highs are looking pretty serious, but neither to make sure that we have covered those points. Is that okay, Sally?
Yeah, certainly, yeah.
Okay. All right, thanks very much. Right, we move on to item 5. Neil, with service user and carer involvement, please.
Thanks, Andy. So we're presenting this slot because as a trust, we're really keen to learn from people who receive our services, be that families, carers or patients. So it's a broad group we want to learn from. Worth reiterating that as a trust, we've challenged ourselves not just to focus on individual stories, but to look at how people's lived experience is actually being used in co-production within services. So we want to look at how this is being used and the effects it's having. The presentation today is part of a series. So we've been visiting our involved groups. The board have been going to ResearchNet groups and Can You Understand It groups to try and understand how lived experience is being used. And we also used our last strategic away day at the board to go do a deep dive into a family's experience of using our complaint system. So it's a range of the different activities that we want to look at. 5-minute film we're going to show today is an interview of a co-chairing innovation that we're doing in one of our strategic work streams. I'm really grateful to Gemma Evans, Daria Chemist, both of whom are involved members with lived experience of receiving our services, who, amongst other roles in Oxleas, co-chair our Zero Delays group with Mary Mason. So I asked 3 questions in this interview. The questions really were how co-chairing such a group actually works, so we can understand the power sharing. What impact having lived experience in the chairing role has on the outcome of the work that we're doing. But also, because it's an innovation, what are we learning? What should we be doing next? So I'm now just going to play the film. It'll be really interesting to hear what they say and take questions after that. And this is where Great. So do tell me if you cannot hear this.
Yep. And we are actually co-chairing that meeting, and I think it's really important because it shows that we have a presence right at the beginning, right at the top level, and even just I think being there the message and the power of that is important. Some things that have worked really well for us are, for example, having a pre-meet. Before we have the meeting, we'll meet up as co-chairs, and we go through what the meeting's, how it's going to run, what parts we might be involved talking about, and anything we're not clear about. So it's all kind of planned, and that's a chance for us to ask questions, etc., and makes it kind of the information more accessible. Then we have the meeting, and then we'll have a post-meeting as well, kind of like a debriefing, and that works really well.
I always felt quite, I guess, in a nutshell, I always felt quite empowered because there is a lot of respect going back and forth between the managers and us. And to be honest with you, I never assumed that much before I signed up for it. So it's a pleasant experience, and it's a pleasant, sort of surprisingly just wonderful co-working all together. And also it's a very integral atmosphere. So they respect us, and then we all know the rules and things, but sometimes we have disagreements, and we could either write them an email, or we would just say that out and open in the meeting. But there's never a negative feeling towards that disagreement. It's always quite constructively taken and constructively fed back.
What do you observe in terms of it making a difference to bring in lived experience at this chairing level?
Yeah, it definitely kind of grounds the discussions in reality. We've experienced potentially some of the issues that are being discussed and what that actually feels like. And I think it helps everybody who's listening to be mindful and remain empathetic to, the patient's perspective and point of view.
It's all about them understanding how our past experiences were within that service. But sometimes I feel like it can be, I'm saying this in a constructive way, it could be like a bit of a role play, or making them go into our shoes and then just understand how we felt. I think that is the key to this whole involving in the co-chairing, because some of those people sitting in the meetings, obviously we don't know their backgrounds, we don't go personal with them, or they may not have had anything to do with the experience that we had. And sort of you see faces changing in the meeting, and then it becomes quite, if you like, authentic and quite organic, because they say, oh, right, interesting, but they don't necessarily comment back, but they give us their body language and then the support towards that, because the things we say or the things we complain about, it's just because we genuinely believe in it, we genuinely seen it.
What do you think as a board we should be focusing on? Based on your experience now, what can we learn from this co-chairing?
I think generally it is really well received, and especially in the zero delays meeting. But I think there's still some way to go in terms of culture change and winning kind of hearts and minds around to this idea. Sometimes we feel like maybe people aren't that receptive, and everybody's very respectful, and I can completely understand. So it's kind of getting across, probably staff training. If you're educating staff that this is now written into legislation from, government legislation, NHS England statutory guidance, involvement there's a reason that this is the way it's going, and that's because it's been shown, to reduce costs, improve outcomes, improve patient experience. I think it's important to get training filtered into the involved staff and also the involvement members, because a lot of the time it's staff will be looking to us. If you're the person with lived experience on a board, they'll be asking you, how do you want to work with us? How can we best get the best out of your experience? Even if they're really open, and we don't always have that training or the answers.
What I'm learning is that there is so much to do, and it's almost and there's not enough meetings in the world that we could have and then just produce the best quality service known to mankind. But it's difficult. There's always a balance act, because that things we need to look at things a bit realistically, and as well I think that's what always is back of my mind, thinking there's nothing has to be perfect, but we can always carry on improving as much as we can.
A really interesting film. I think that interview was Monday. So it was fascinating to sort of have this window on them. Very happy to take questions. For me, some of the core points were grounding, conversations and experience, what actually happened, and that not everybody can see all sides of the picture. So you need people who are receiving services as well as living, but also the need for us to keep developing training. I've been discussing that with Jacqueline, our involved lead, and the plans are that we're going to keep producing that, because people are telling us when they go to different committees that they need different forms of training, because actually there are different issues in each of the committees or each of the sort of work areas. So we need to have a kind of common foundation of training our lived experience practitioners to be involved, but also some bespoke trainings, particular to the areas of work that we're doing. Very happy to take any questions, Andy, if we have them.
Thanks very much, Neil. Are there any questions for Neil? If not, thank you very much. That was very, very helpful, Neil, and we'll be looking forward to further updates in due course on the work you're doing on this front. So thanks ever so much, and thank you to everybody involved in the production of it and who appeared on. Well done, thank you. We just move on now to my report. Last time we met, I talked about our new Secretary of State and her plans, and of course we've gone back to the Secretary of State before that now, and Stephen Barclay, who I have met. Clear warnings over budgets. I mean, they're talking very much about the efficiencies, which we know will mean potential cuts across the whole range of public sector. So that's going to be a very challenging time ahead. We'll talk about this in the business as far as our own finances are concerned. A lot of moves to reduce central costs. Whilst we don't, we're all concerned about everyone in the NHS, it's quite clear, I think, on the setup of the ICSs, there are opportunities to reduce headcount. Because if we keep employing people at the centre, taking the funds away from providers, but also those people end up doing lots of work, which end up often putting demands upon us as far as further demands for data are concerned. So I think there's a healthy look at central costs, which I applaud. System pressures, and I've circulated the winter planning guidance that's come out, but clearly elective surgery, delays at ED, and we know that we're potentially facing real major problems with COVID and flu coming up. Bringing that down from the national to the local. I did again circulated this from Andrew Ridley, but very concerned about mental health trusts, about length of stay, about our crisis plans, our partnership with other organisations, our discharge policy, alternative pathways, Section 136, ambulance cars, and reopening of beds which were closed. I think he's leaving us quite soon, but he was very clear that he expected that boards will be discussing these issues, and no doubt these matters will come up through today's discussions. And I've been out and about doing some visits, Green Parks, Woodlands, Bracton, ALD, and district nurses yesterday, which was quite a powerful afternoon of talking to our district nurses, and I see that will crop up later on in the papers as well. But I find time and again, apart from those constant themes around demand, complexity and staffing, very enthusiastic staff who want to get on and do a good job. The themes that keep cropping up, almost every visit I've done recently has been around the everyday. It's around parking, it's around fuel costs, it's around quite basic issues, which I know we've talked about before. But again, I think this will crop up in some of the papers later on. But we've got to find some way of at least answering this. If we can't do it, we've got to be very clear about what we can and can't do. I think this is a constant theme that keeps coming back on just about every visit. And when you do repeat visits and they keep saying the same thing that they said to you last time, it will be helpful for us at least to have some position on it. We've either exhausted all avenues or that we have some plans in place. Any questions for me, colleagues? If not, then we'll move straight on to you, Iffy. Thanks very much. think you're on mute, Iffy. Anyone else here, Iffy? No. It's universal. If you're struggling, Iffy, we might move on to Ian's report. You can't get in.
I'll log out and come back in.
No,
We can hear
Can
you
you hear
now.
me now?
yes.
I have no idea. And I'm in Pinewood, you know. So sorry about that. So just a few things to highlight in my report, and then I'll be happy to take questions. First thing I want to mention is the annual members meeting and the awards, which was a real success. It was really wonderful to see so many colleagues and a great opportunity to recognize and celebrate our staff and our teams. We've had really remarkable feedback since that event. So my thanks to all of those who contributed in that. You would have read we welcomed 4 prisons in the Southwest. Ian and I did the rounds, met our new staff, met prison governors, commissioners, and I know that Ian and Lawrence have plans in place to begin regular meetings with mental health trust partners in the Southwest, just to make sure that we have seamless transfer of users who may require local mental health services. Our annual staff survey is ongoing, so at every opportunity we remind staff. I was told this morning we are 26% and Rachel Clare has got it behind her, just in case anyone has missed it. A few other things to mention, not in my report. I know that later on this morning Jane will be taking us through our annual Mental Health Act report. NHS Digital published only last week the outcome of the review of 21-22. Jane's report covers 2022. But I think the summary of it is not a great deal of difference. And so I'm sure when Jane comes back next year, we'll probably hear pretty much the same thing from a national point of view as she'll be sharing with us this afternoon. The second thing is that the CQC Community Mental Health Survey of all mental health trust providers was published again late last week. This is a survey of users of community mental health services. Again, they say that broadly no different from the survey they carried out last year. The positive finding was that people were quite satisfied with the way that their care is organized, but there were still areas for further work, including access, crisis, involvement in care, and support, well-being, and communication. We will be looking at our own report next week, and I'm sure we'll come back either through the board committee, PIPWA committee, with our response to that. The board will recall that when I at the last meeting, I talked about an ever-rising number of NHS professional groups who have been balloted, and we received only a few days ago a letter from NHSE about our preparedness for potential industrial action. The letter sets out that ICBs will help coordinate planning for any potential industrial action, and trusts will need to complete a self-assessment checklist and also put in place steps that we're taking locally. And I think it's important to assure the board that Ian, as the gold command for Oxleas, has already had an initial meeting, but we will keep the board informed once we hear of any strike action. Finally, I'd like to draw attention to the healthcare worker flu vaccination best practice management checklist, a mouthful, for public assurance, which the board is asked this morning to approve. And that's all I wanted to say. Happy to take questions. Thank you.
Thanks, Iffy. Just think about the strike for a moment. Have we got a risk on this? I actually can't remember. Stephen, please.
I thought we had under the people committee, actually, I thought. But if Sue Owen's on the call, she'll probably have more up-to-date information on that.
We don't, I'm afraid.
Okay.
Rachel, Claire, and Ian want to come in, and if that's okay.
Yeah, Rachel, please.
Yeah, so we do have a risk which is about staffing more generally, and of course the ability to keep the show on the road will depend on us having the right number of staff, and industrial action could really impact on that. But that was going to be one of the points we'll be discussing with People Committee in November when it comes to reviewing our BAF risks.
Thanks. Ian, please.
Yeah, thanks, Andy. Just in relation to the strike action, so as if he said, we've been communicated with by the RCN, so we have an idea of the numbers of members of the RCN within the organisation. We're obviously waiting to hear around Unison. Colleagues in the emergency planning team have participated in a meeting this week. I think it's fair to say that there is understandably some anxiety, not just regionally but nationally, around the strike action, and obviously the timing of it as we go into winter, concerns around staffing absences due to COVID and flu, but also other risks that are kind of bubbling to the surface around fuel outages, things like that. So I think the good news is that because of COVID, we do have as if he says, a robust kind of central command structure to help us manage this. We have had experience of managing strike action previously, not for some years. So I think we will obviously now start to ramp up those discussions. And I've got a further meeting planned with our ICC on Monday morning.
Thanks, Ian. Stephen, please.
Thanks, Andy, and thanks, Iffy. A couple of observations and a couple of questions. Observations first, on the Governor Induction Seminar that you and I and Andy attended yesterday, it did remind me about how well we'd done on the regulatory framework, Tier 1. And I don't think as a board, probably we've sort of commented on that enough. You know, when I look at the detail, it basically means we're consistently high performing across the 5 oversight themes, and that we should in a position to offer peer support to other trusts, whether they want it or not. So I think, just to say, it is a fantastic achievement. And I know we said before, we'd equally wouldn't be unhappy to be in Tier 2, but the fact that we were in Tier 1, I just wanted to say it made me think again on reflection, well done, because it really is brilliant to do that. The second observation, I know we touched on measurement of, under the NHS provider licence, we touched on about measurement of outcomes for inequalities before, but both for inequalities and digital maturity, I don't need a comment now, but I just think at a later stage, through Ian and yourself, it'd be really good to know how we are going to measure that, because I do appreciate that they're both very long-term, in some respects, generational things, but equally, it's good to see that we are making progress in those areas. So as I say, I'm not asking you that question now, but I think on another meeting, it would be good for you or Ian to come back and say, this is how we're going to show that we're on the right route to progress in those 2 areas. The 2 questions I had, one were again on the NHS provider licence and the patient choice theme. How do you see that impacting us, if at all? And then the second thing, which is probably more important, this touches on the industrial action, and I'm particularly thinking of the leak reports recently, and it was only a leak report, there could be reasons for that, of a 2% pay rise for public service workers, including the NHS, which in effect would be a cut in real terms of 7.5%, which I think would have a huge bad impact if that was followed through. So I just wondered, within your role as chief executive and within the South East London ICS, etc., are those ideas floated around, and is there being any pressure put up from you as chief executive and other chief executives to say that here's just to warn people of the additional problems that would arise if that was followed through.
Thank you, Steve. I feel I ought to start by commenting on us being in SOF 1, which is something that we really should be proud of. I see Azra has commented just 6.5% of trust are in SOF 1, but I also wonder whether that's the reason why we are looked to quite often for support in Southeast London ICS. And I have said to one or two of our partners, we'll be more than happy to support them in whatever way we can, not just financial. On the provider license, I think patient choice has been around for a long time. Now, what I don't know is whether this, subject of course to the outcome of the consultation, whether there's going to be a requirement to extend this further. Not many of our services are affected, but of course there are services such as our service in community health, where the GP or patients can choose any of the providers in the local area for rehab, for example. Regarding industrial action, I've got to say that this has not really featured in any of the meetings I've been at. You know, much of our conversations, such as the last chief execs meeting of London chief execs, was more about the fact that consultants are choosing not to do any additional work over and above what they are contracted to do. And I'm not sure if you're aware that the British Medical Association had published a rate card, which they are encouraging consultants to use when negotiating with trusts. And the implications of that has been that elective recovery work has been grounded in some trusts. You know, I've heard from our neighboring trust that they've not been able to do any work over the weekends because anaesthetists will not agree to do any work. I suspect that part of this is that we all probably have our heads buried in the sand, hoping and wishing that there won't be any industrial action. But in the light of this letter that has just come to us, I think that those conversations, no doubt, will keep.
Thanks, Iffy. Nina, please.
Just a very quick point of order, Andy. We haven't formally accepted this as a risk from a People Committee perspective, but we did have a discussion at the last People Committee about the risk of industrial action. And in particular, we wanted to know how Oxleas had fared previously, because I wasn't on the board at the point of the last industrial action. So we are going to have a fuller discussion in 2 weeks' time, and we will report back to board colleagues, obviously accepting that this is a live situation. We're not going to wait until the next board meeting.
Yeah, thank you. Jim, please.
Thanks, Andy. Thanks, Iffy. Just a quick question on the ICS finances. I can see that there's a forecast deficit, and that there's going to be something called increased management controls. And again, there's a newbie. What does that mean? Have we got any idea of what that, through Chinese whispers, what that might be and how that might affect us going forward?
So it's really a proposal from the directors of finance to chief execs, and we've agreed this, that we will not use management consultancies as a way of making sure we don't continue to spend, you know. And Azra and I have already had a discussion with colleagues that there are some instances where those of them that are in flight with things we've already committed to, we're going to work with, you know, but no new arrangements to be put in place.
Thanks. If you, Joe, please.
Yeah, I just to say to that, whilst I don't think we would be surprised if that's the result, I think formally there isn't a forecast of a deficit at the moment at the system level. We talked a little about this in the pre-meeting, so just in terms of making sure that we're in the right place on the minutes. I think my sense, Iffy, is that what we've been told so far in terms of restrictions in terms of management consultants doesn't give us any concern. I think if the next potential layer of restrictions could be more tricky, I think, and particularly if they're headcount related.
Sure.
Ezra, please.
So I've just been raised, there were a couple of other areas where people had been asked to focus on. One was around agency spend, But as we know, the board had recently agreed at the last board meeting that we would exceed our budget by 20%, and we are below our pay budget. So we've played that position very strongly back, Iffy and I, in the conversations. Secondly, there was something about ensuring that everybody's control environment was at the highest level. So there's some benchmarking work that is going on in regards to that area, and everybody is currently conducting internal audit interviews on their control framework, and that's similar to us, which will be reported back through the audit committees and the board. So that piece of work should finalise in November and come back, and there should be some benchmarking that we'll receive from KPMG coming out of that work as our internal auditors.
Thanks very much, Ezra. Okay, thanks very much on that. Can I just repeat the well done for Soft One? I think, on behalf of the NEDs, congratulate the team for the outstanding work to get us into that position. And I think we're very happy to offer advice to any other trust that would want it. We're looking for a risk for around the strike action, so whichever route this comes, we need to have that on there. And I just want to echo the points you made, Iffy, about the annual members meeting, and I thought the awards night, I thought it was outstanding. I really did. I was just well done, and thanks to everybody that was involved in the production of that. It was really, really well done, everybody. I move on now to you, Ian, please.
Chair, may I just ask whether the board approves the flu vaccination best practice checklist?
Yeah.
Thank you. Thank you.
Thanks, Andy, and morning, everyone. Hopefully everybody's had a chance to read through the detail in the report. Andy, I think it's helpful to hear the comments from Andrew Ridley, and hopefully you'll have seen that we've tried to weave in our response to some of those comments in the reports themselves. But I will go through and highlight a few things. I think like last board, and as reflected in the board assurance framework, we've still got significant pressures across all our service lines in terms of demand and capacity. I think there's an awful lot of work going on in all areas to try and transform the way that we work to meet some of those pressures, and I'll go into some detail in a moment, whilst at the same time continuing to deliver business as usual. And of course, as your visit to the district nurses highlights, delivering business as usual is not without its challenges, given some of the kind of wider economic and societal context that we're all living through at the moment. So just starting with acute, still considerable challenges for our bedded capacity. Although interestingly, we received some data that we requested from NHS England yesterday, ahead of a summit that Iffy, myself, Abby and others are attending next week around mental health in ED. And it did show that actually overall presentations at ED by people with a mental health issue have reduced, which I'm taking as early indications that positive changes are being made out in the community. But having said that, those that are attending are more likely to be subject to a decision to admit, and so we are still seeing reasonably high numbers at times of 12-hour waits, which are related to our ability to meet that demand. So in terms of what we are trying to do, there is a huge focus on our length of stay and reducing our delayed transfers of care, which is the specific point about people residing in beds when they are medically fit. And the numbers are coming down, which is good. There's considerable work taking place between Ashling's Directorate and particularly the Royal Borough of Greenwich, where we have hotspots in terms of demand around accommodation. Having said that, we've got a number of voids at the moment in terms of our supported accommodation pathways there. So I think there is a kind of there's an area to focus on, which we will continue to do, and is the focus of work across both Ashling and Lorraine's directorates. We're also looking to increase our capacity, and we are hopeful that we will reopen one of the wards that we closed during COVID at Green Parks House by the end of the month. Huge amount of work going on to recruit staff, and I think the directorate should be congratulated on what they have been able to achieve, given the struggles that we all know about in terms of attracting staff. And the crisis house, which has expanded to 7 places, is now operating well in terms of as measured by that capacity being used to its kind of maximum potential. Areas to kind of continue to focus on as we go into winter is that proactive work to again across the directorates to focus on people who are high intensity users of ED and therefore of our beds. So where we know some of these individuals, it's about looking to see what we can do to kind of help them kind of maximise community resources. Just to say that even when we open the ward at Green Parks House, there is a lot of concern, I think, around winter pressures on ED. Mental health demand doesn't go up during winter, but obviously pressures on ED increase. And so as good system partners, I think all mental health trusts are looking to make sure that they have some block booked capacity in the private sector, but also through the Cavendish Square Group, Coup Group, we have also secured 40 beds over and above that in the private sector to manage any surges in demand we have over winter. Those are not being supported financially at the moment by the region, but I think in terms of demonstrating a proactive offer, it's a good thing to have in our back pocket. So moving on to the community, as I've already mentioned, there's an awful lot of work going on across directorates to try and meet people's needs in a crisis. But I just really wanted to emphasise what was in the paper around some of that longer term transformation work, which is outlined that all mental health trusts should be delivering in response to the long-term plan. So the paper sets out how Lorraine's directorate has, in the process of implementing mental health hubs at place. I think these are really significant developments in terms of they are a tangible manifestation of our working in partnership with other organisations systemically, building on the work that was established during COVID, and really importantly anchors our secondary care mental health services within that wider system to better meet people's needs, and ensures that over time that secondary care mental health is there for those that really need it, which will then help us to focus on those individuals, which will then help us to hopefully reduce demand for beds. So there's a kind of a gain for us as an organisation, as well as a gain for using services and just meeting demand better. Lorraine's gone into a lot of detail in the report. It's not without its challenges, but it is progressing positively. And at a recent local care partnership board in Greenwich, there was a presentation around mental health in the borough, and there was really positive feedback from GPs around the hubs, and that's that's really positive, I think, given working with general practice is not without its challenges. They are, meeting a lot of demand themselves. So I think getting that positive feedback is excellent. In terms of adult community physical health, I just wanted to highlight that we successfully completed the change programme around the resizing of our intermediate care bed base. This was a fantastic piece of work undertaken by Sarah and her team. There was a lot of, if I'm honest, trepidation about entering into that piece of work, but really good engagement with system partners and with staff themselves. And it's been a real success. So we are working within a reduced bed base, which has now been consolidated at Meadowview, and we continue to work well within that bed base. So early indications are it was absolutely the right thing to do. Yeah, I think the team should be congratulated. Source has reopened in Greenwich. I know, Andy, you have been along, but really good feedback, I think, from local residents, although I think understandably they would probably like to see more, but that is something that I think we will continue to take through place-based discussions. I think it's also a really good example of what we might see more of at a neighbourhood level, which is local residents working with services to say that this is what we need locally. And I think one of the things that I'll be taking from this is feeding it into conversations that were previously raised in the Thamesmead area, where I think similarly local residents are quite clear about how they think services should be organised to meet needs. So I think it's a really interesting initiative. You'll have seen from the board assurance framework that across all of our community services, so mental health, all ages, but also our physical health, we still have significant risks around demand and capacity. Andy, you mentioned district nursing. There is continues to be a specific risk around those services. Those risks are not things that can be, although there are mitigating actions taking place, I think the return on those actions are going to be, in some cases, medium to long term. So I think there is a conversation for us as a board to think about the risk rating and how we kind of manage that. I'm going to suggest that we take some of those back through PQAC to go through them in considerable detail. But in the meantime, staff are faced with some significant challenges in terms of demand and capacity. And just to say that at the last board, it was highlighted the pressures around, particularly around CAMS and particularly around Bromley. We did have a discussion since then at PQAC where Lisa and colleagues outlined the action that is being taken, and myself and Lisa are involved in conversations at place in Bromley around CAMS pressures. And then finally, in terms of our forensic and offender healthcare services, as they are now have been rebadged. I won't go into loads of detail because Lawrence will be joining us in part 2, but I just wanted to highlight that the mobilisation of Lot 1 of South West England has gone successfely. Colleagues were paid, which is really, really important, and I know is a kind of a basic, but it's not without its challenges. And as Lawrence has highlighted in the paper, I just wanted to thank central corporate colleagues and their teams for supporting that. It's been a huge effort, and I think the Directorate is very grateful for the support that they've received. And the other thing to highlight in terms of, particularly in terms of prisons, is that we have had recent re-inspections by HMIP and CQC. One of those inspections was positive at ISIS, but issues have been raised in terms of some of our Kent prisons and we are working through our response to that. But I just wanted to highlight the areas of focus, and I guess just finally, that is a reminder that we need to focus on, as we expand that particular area of work, that we need to continue to make sure that we are on top of the day-to-day running of services and on top of performance and quality. But I'll stop there and very happy to take any questions.
Well done, Ian. Thanks ever so much. Yemisi, please.
Thanks, Andy, and thanks, Ian, for that report. It was more of a comment, really. It's the fact that we know within the system, in every trust, there are pressures on demand and capacity in terms of patient acuity, workforce issues. We know it's there. But what I really got a sense from reading the papers this month was that strong sense of partnership working at place-based and at system level. And we seem to have managed to really ramp that up in terms of the focus on our transformation plans, our reset plans, our change programs, that they've really come to the fore, and it's really pleasing to see. And not only that, I also got a strong sense that those collaborations that we're making, that they're not static, and we're constantly monitoring them. And there was evidence in acute and crisis of where a particular project has been changed and altered because we weren't getting the outcomes that we wanted to see. And all of this while we are doing business as usual. So I think as a board, it would be good to pass on our thanks to the directorates and to the staff there who are doing sterling work, because we do understand the pressures in the system as a whole, but how they're coping with it. Thanks.
Thank you, Yemisi. I really appreciate the comments, and yeah. and I think it's a good point about things not being static. I think it is something that we really need to focus on, which is about responding quickly to kind of situations and doing something about it. And it requires a degree of nuance, I think, in terms of how we then kind of negotiate that with partners, and how we and it's a test of maturity as well. But thank you. I will certainly take that back, and very grateful for the feedback.
Thank you. Jo, please.
Yeah, I would absolutely agree with that. I mean, I thought it was a really useful and helpful report. And I was also struck by how much we were doing and the complexity of how we move forward with partners. It feels like it should be the right way forward, absolutely. But in many ways, it's easy just to do something as a trust, isn't it? Rather than, like you say, the level of negotiation and sensibilities and such to work with partners. So, congratulations to everyone involved with that. I welcome the increased focus on high intensity users that is noted on page 60 of the bundle. When I read the Mental Health Act report, I was quite taken by the fact that we have people with, a significant number of repeat sections, and that was just within the year. I'm sure we might also see some of those individuals in previous years. So working out how we can help those people perhaps in a slightly different way feels a good idea to me. And then I just had one question in relation to PCP and the number of referrals in PCP. And I just wondered whether there is a sense that GPs are holding on to less mental health patients than they did pre-pandemic, or is it that the genuine number of people with need and higher acuity has increased?
I mean, Lorraine may want to comment on this, but my sense is that referrals have genuinely gone up. There's a distinct change in the pattern of demand since COVID. I think the conversations we're having at place is to try and get behind this concept of mental health and really to try and define what we're talking about. So often when we talk about kind of increased need around mental health, it's around the fact that I think the pandemic and kind of other things that are going on at the moment are really having an impact on people's resilience. And so I think I think GPs are experiencing higher volumes of people presenting with difficult living circumstances, and there's a limit to what they can do. So understandably that changes the kind of pattern of their referrals on. But I think this is where the hubs really come into their own, and as Lorraine has outlined in the paper, by bringing together a range of different system partners, we can really think about how we get people's needs met in the best possible way, and try, and I think I mean this in a positive way, to kind of demedicalize some of those presentations, because frankly, if you've got a situation where you're worried about whether you're going to pay your rent, how you're going to feed your kids, it's a perfectly normal reaction to feel quite anxious, and over time perhaps feel quite low. And formal psychological therapies isn't going to cut it unless we address those kind of more those kind of wider determinants. So I think that's always been around, but I think it's you know, circumstances mean that it's a kind of growing issue. So I think that hub model is really going to make a significant difference, and that's the feedback I'm certainly receiving from kind of local care partnership boards, but I know Rain is involved in a lot more detail.
Thanks, Ian. Stephen, please.
Thanks, Andy, and thanks, Ian. And certainly on board visits that Lorraine and I have made recently, we've heard those comments about GP thresholds being a lot lower, and hence more referrals. So I think there is some action to be taken. But firstly, as people have said, when you look at the 39% increase in referrals in certain areas, and the 6 significant risks, and which Andy touched on earlier, which compares to 3 last year, by the way, but 6 is the most we've had. You know, you've got to say for the staff, they are doing a fantastic job with much more work, high level of vacancies, and much more acuity at play. So, you know, congratulations on managing to fight through that. And also, I love the work at Bromley College. I know the council, Bromley Council, who perhaps aren't always our biggest fans for various reasons, but I know they've also heard of that work and were very appreciative of it. The feedback you got was great. I think there's something like 10,000 students enrolled at that college. So, you know, it's a big project, and anything we do there is going to be well received. Three questions, Ian. You refer page 59 to the work we're doing with LAS, and how they're going to directly employ some mental health staff. It set up a little alarm bell. Are we likely to lose staff to that project? Would they recruit them from us? I realise that may be for the greater good, but that was question number 1. Question number 2, on the Scabbery situation, has that work now started? And has the, I suppose I've got to call it a dispute between King's and the PFI partner, has that been resolved? Because if it hasn't been resolved, of course, that means that problem goes on for a long while, or forever. And then the third question is 72-hour discharge and follow-up. And I do appreciate that when you look at the data, it is improving. But I nevertheless, I know we've talked about it before, but I always find it is frustrating that it's not 100%. So just digging a little bit deeper on that, is that because the fact that we don't hit 100%, is that because of lack of staff resource, or is it staff error in some way? You know, they've forgotten to carry out the follow-up. It's just, I think it's such an important area, which of course has long-term implications about people coming back to us on an additional visit, that it's one that I'd really like to see us get on top of. So 3 questions for you.
Thanks very much, Steve. So I will take them in order. So the mental health joint response card with the LAS is something that has been in place for quite some time. So we have staff who we employ working within that service. So we've had a couple of staff that have been deployed into that area. This is seen as a positive move for the LAS to employ those staff, because there are times when that car isn't possible to be deployed because of kind of other pressures within LAS, as I understand it, and their own staffing issues. And so those staff can be left without a job to do, to be honest. And we do try and employ them in the best to the best ability that we can. But I think if they're employed by LAS, there will be kind of greater kind of focus on making sure that they are deployed usefully. And also, I think that the car does run. And we, I think within Oxleas, like other trusts, do feel that this is a good thing to focus in on. You'll have seen from the report that we have pulled out staff from working with the police. My view was it was always, you know, we shouldn't be kind of, it was too much to try and do both. So I think what we're trying to do here is to focus on the LAS joint response car, get the most out of it. And Aisling is very supportive of this as a way forward. I don't think we will lose staff because they will be employed by the LAS, but operationally it will make delivering the service a lot easier. In terms of Scadbury, I can see Rachel is with us, but Rachel and her team have been involved in quite a lot of conversations with Kings, and I have also with the site chief executive. So Rachel, are you able to tell us whether the work has actually started? Because I think I said in the report it's about to, but
yeah, the work on Scadbury has started, and there is a plan for it to be completed, I think, later in November. So there'll be phased completion so that the ward can begin to be occupied. The dispute is not resolved as far as I'm aware. We have another meeting with Kings next week, but there is a mechanism in place to take forward key pieces of work that are safety related.
Thanks, Rachel. And then the last question, as I remember, was about 72-hour follow-up. So you're absolutely right, Steve. This is a key patient safety indicator because of what we know from research, that the kind of vulnerability of people post-discharge. Meeting the 100% target is always going to be a challenge because there are occasions where, despite people's best efforts, patients are not contactable within those 72 hours. What we look at the exec and PQAC, we try to delineate breaches which fall into that category. So where we've tried all efforts to reach somebody, from breaches where the process has broken down. So the area where processes are broken down, that's what we continue to focus in on. And what we want to try and do is to eliminate, if you like, fault breaches where basically our process is broken down. And you know, where we can try and close the gap on the non-fault breaches, i.e. things that are outside of our control. But we do, the exec and the PQAC will start to receive narratives around where, you know, what has happened with individual cases where they haven't been followed up within 72 hours, so that there is a kind of system of assurance that people have been followed up, even if it's several days later. So that has started to happen within PQAC. So the board can be assured that we're doing everything that we can. Not sure I explained that very well, but hopefully you got one then.
Oh, well done. Thanks ever so much indeed, Ian. Grateful. We'll move on now to item 9, Oxleas strategy. That's Rachel and Lorraine. Who's going to lead us on this one?
Thanks, Andy. I think that's me first, if that's all right. Can I just check, do you want me to share the slides, or are you content that people can see them on their devices?
If you could share them, if that's okay, please.
Okay. Okay. I can't see any hands now, so if people want to interrupt them, feel free to shout out. So this is around our zero delays update, and you'll all be familiar now with the concept of our priority around zero delays. So aiming to ensure that we have those effective systems in place to respond to demand for services, to ensure that our teams are managing their waiting lists effectively, and that services are developing ways to reduce those waits as part of the work with the wider system. And we want to enable our patients and our staff to have a mutual understanding of expected waiting times, and that people have got support whilst they wait for services, and that we're doing everything to eliminate those unnecessary delays. So we thought this time, so we've done a lot in the past around our work streams, and I have got a brief update on our 3 core work streams, but we thought it would be good today to show you some of the progress that some teams have made. So we've picked a couple of examples that I'm hoping will just help to illustrate the work that's been happening. And I think it has to be said at this point that this is in the context of a different climate to the one that we started this work in. So obviously there has been an impact on this programme in terms of the increased demand and fluctuating demand, but also our workforce pressures. So they do have an impact that actually makes it more important for us to focus on this area. So I don't think we're saying that it's been an easy ride, but it's certainly been one that we think has value, and that value is only increasing with the demand pressures that we're seeing. So the first example is around our adult ADHD services. So this slide just shows you the pattern of demand for ADHD adult diagnosis, and you can see that there's been a huge increase in demand for that service, with some over 180% in some instances in the boroughs increase in demand. And the capacity for that service was designed for a demand profile pre-2019 of around 150 assessments per year. We've had 2 months where, in fact, the last month where our monthly assessments have reached that peak. So it's a huge issue for that service. They were the first team to be onboarded to have their waiting lists on Rio. So previously their waiting lists were held on spreadsheets by the team. They were managed well on those spreadsheets, but you can see on the graph that the Rio wait lists were introduced, and that enabled them to categorise their weights. So what they found when they did that work was that there was some duplication. So actually we saw a slight improvement just based on the mere fact that those referrals were transferred onto the system, and it reduced duplication. And also there were some people that were waiting who had already received a diagnosis, and they were there for a medication review. And actually the primary purpose of this team is to provide a diagnosis, and our medication reviews are managed separately, so they were removed from the list. So that reduced our waits a little bit. We then did some work. So another key part of the Zero Delays programme is around QI, and looking at what the issues are, why there is such long waits, and the waits really are eye-watering for this service. And some of that was around that historical commissioned capacity. So we did some work as part of the South East London ADHD working group, and both providers, us and SLAM, were able to get some additional funding to try and match our capacity to the current demand. So at that point, our assessments increased from 30 to 100. It's also important to say that in terms of the QI work that team were doing, and the introduction very recently of a clinical lead helped to boost that. So actually, if you had just looked at it from a financial perspective, it increased from about 30 to 75. And then the work that the team have done in terms of really pushing productivity and efficiency and being really clear how many assessments clinicians can do per session just enabled us to increase that to 100. You don't see a really sharp drop on the graph, which is what we would like you to see, and that's because of the backlog. So despite the fact that we've just about now got the right capacity for current demand, that hasn't dealt with this kind of huge backlog that we've now got. So again, through our work with the ICS, we now have some funding to clear the backlog. And we've been able to begin to produce a new trajectory for that service, which will and aims to bring down our steady state position, so to March 24. So by March 24, the backlog should be cleared. There should be then enough capacity to meet current demand. It is an area where demand continues to fluctuate and increase, and that's obviously a concern. But assuming that it doesn't increase too much, by March 24, we will have enough capacity to meet demand and will have cleared the backlog. And that will be a huge difference for people waiting for ADHD assessments, where currently they're waiting in some instances in excess of 3 or 4 years, which I think everybody would agree isn't good enough. And then the next piece of work, just to illustrate what we've been doing. This is adult community health services. So whilst services are waiting for RIO functionality, they are finding other useful ways to report service waits and to develop that data so that it's well understood by both the team and the wider system. So this was something that had been produced by Adult Community Health Services that showed how many people they had on a waiting list and what their median and mean waits were. However, it didn't show their target waiting time. And one of the things that we had been really clear about with the Zero Delays programme is that it was important to know what the targets were for services, because we had to have a sense of when you look at that data, is it good or is it bad? Where do we need to focus our energies in terms of thinking about how teams might need to work differently? And so Adult Community Health Services have now added some target wait times as part of their suite of information. And I think that has really enabled people to, when they're looking at that data, see whether or not actually that median and mean wait are good or bad or about right. So we are beginning to do target wait times for all services. It's not without its challenge. One of the things that we've had a lot of debate about is how easy it is to tell patients what the target wait time is, because that was certainly one of the ambitions of the programme. But there are some services that will reprioritise people based on need, and actually that then means that sadly some people will end up being bumped down the waiting list a little bit, and that's quite a hard message to give to patients, and teams are having to think very carefully about that. And our service user and carer reps in all of our groups who are well engaged in the Zero Delays programme are very divided in terms of how much of that information they think it would be helpful to share. So it's something that we're currently grappling with. In terms of the 3 main building blocks for the Zero Delays programme, one of our key work streams is around waiting list management. So this is predominantly about digitalising our kind of information, making sure that all of the teams have a waiting list that is on RIO, that have links to IFOC so that they can see how much they're waiting. They can produce reports that show how many people are waiting and what the length of their waits are likely to be. And so this just shows what's happened so far. So 124 teams across the trust have currently been engaged in that programme. Sue Horbury's team have produced a really good detailed onboarding document, and they've onboarded 17 teams where the waitlist functionality was already enabled. So it's important to note, I guess, that for some teams they have single waiting lists, others require multiple waiting lists. We've been doing some work, Alison and colleagues with Servlec, to introduce multiple waitlist functionality to Rio. That has been delayed, so we've had to rejig this part of our programme a little bit. But what Sue's team have been doing is ensuring that all of the teams that require single wait lists are onboarded and have that functionality in place ahead of us having access to the multiple waitlist functionality, which is currently targeted for next February. They've also developed an e-learning package for staff, and they've developed metrics for the teams to view the proportion of their patients that are breaching their target waiting time, and those reports are within iFox. And some of the things that they're planning to do, there's going to be a huge focus on testing the multiple waiting list functionality before it goes live next February. They're continuing to work with both supplier and our neighbouring trusts around that work. They will make sure that some of those teams are part of the testing for that. And they will deploy that at the same time as doing our level 2 services to try and make sure that the delay isn't too great. And then our next building block is around our patient access charter. So we had a working group, which was a cross-section of our staff groups and a service user. They came up with a fairly succinct patient access charter. That's now been produced and signed off. It has also had a little video that went with it ahead of the AMM launch, and it's gone through various kind of governance processes. They've also produced a set of principles to be included in our waiting letters, and that included administrative colleagues, and has also gone to a number of service user groups. That's where I think we're not there yet in terms of being able to agree what information will go in that letter, because I think there is still, as I said earlier, this debate about how we communicate waiting times if we think they may have to change based on reprioritisation. We did the showcase at the AMM, and I think that had some good feedback. There's been a lot of work with comms. We've had some nice input into making the charter look lovely, and we've got the seeking approval of the principles for the wait letter is delayed until we can be really clear what needs to go in that. And then our final work stream is our QI collaborative. So we had the benefit of some improvement seminars from Morehouse, and the people that engaged with those have now joined the collaborative. And we have, as you heard earlier, 3 service user improvement collaborative co-chairs. That's been a really excellent kind of initiative, and I think we can't underestimate the value that that brings to that group, because that's where the QI collaborative is where all the kind of good work happens for zero delays. So this is where teams are engaging in programs to change the models of service delivery to improve their waiting times, to think about how they might do things differently, whether or not they should prioritise referrals, all of the really kind of important and sometimes kind of knotty decisions are kind of happen in this space. So it feels really important to have those co-chairs and to have that sort of challenge, which I think sometimes helps us to think differently. So the really nice thing about the QI collaborative is it isn't just all about QI projects. Each of those meetings starts with a brief QI or data masterclass, which is really enabling staff to think about data and how they use data in a different way. But of course, on top of that, it has also identified some key projects, and so far, those projects are within community mental health, ALD, and CYP. They have appointed a project manager for that work who will, so at the moment, Mary Mason has been leading on that for us, but they've appointed a project manager who will take that forward over the next year. And I think I've probably already covered most of that. So I think that's the end. I'll stop sharing so that people can ask any questions.
Thanks very much, Lorraine. Rachel, please.
Thanks, Chair. Thanks, Lorraine. So we had a really good discussion about this at Transformation Board, and I've been reflecting on it quite a lot since then. And there are two things I really want to commend about this project. So we always knew that mapping and driving down weights was going to be really, really ambitious, really difficult. And I think what's really been highlighted to me, apart from the fact that always the pressure is growing and growing, so we're always battling against something that's bigger and bigger. I'm really impressed with the approach that Lorraine and everybody involved in this has been taking for two reasons. One, I think the level of granularity that we're going to really understand capacity will make a difference. I think a lot of places do that sort of analysis on the back of a fag packet, if I'm honest. And if we really understand the level of capacity that we have in our teams, then we can be absolutely clear what additional money can bring us, what changes of approach can deliver us in terms of actually seeing those downward trajectories on all of our graphs. So I think it takes time to do it that way, but I think it is vitally important that we do it so that we really know what we're battling with here. The second point is about how we've always wanted the strategy to not just have as a strand that we engage service users and patients in what we do, but that we have it at the heart of how we drive every bit element of the strategy. And I think that's done really, really well here. We had brilliant presentations in the videos at the start from Gemma and Daria, in terms of kind of how it was chaired, but also at every level you can see the way the guidance that's given to people about what they hear when what they're told when they're waiting. Really important we get input on that, helping to flush out that really difficult tension between should we be absolutely crystal clear with people about how long they wait, or should we retain that flexibility around reprioritisation? Having those discussions with service users really, really helps us to navigate some of the much more knotty elements of this programme. So I just think there are two bits in there which have been handled really, really well in this programme, and I just wanted to commend those to the board.
Thanks, Rachel. Jim, please.
Thanks, Andy. I think, Rachel, you've just said what I wanted to say, to be honest, because as I said, I really like to commend this because this is a systems approach to a problem with supply and demand, and this is exactly what needs to be done and what happens in maybe other industries. But my second comment really is about the increase in demand in ADHD. I mean, that is a significant increased demand that's a step change. That's across 3 boroughs. So that's not hotspots, that's across 3 boroughs, and it started in November 21, December 2021. So do you have any, going back to Joe's previous question to Ian, this is a sort of granular data. Do you have any idea where that comes from? Because it's across the board, so it seems to be systematic.
Yeah, I think there are a couple of things. It definitely is across the board. So it's across all 3 of our boroughs, but also across South East London and nationally. There are very similar increases. There's 2 potential kind of things that have contributed to that. One is a hugely different public awareness of ADHD through lots of kind of media campaigns that have happened over the last general awareness that's been raised through celebrities, through all sorts of different kind of media outlets. And the second is a bit of a COVID impact. So for people with ASD, and it applies to ASD as well a little bit, there was something peculiar about the fact that in lockdown we changed people's routines, their access to kind of other people, their access to activities in a way that we wouldn't normally see, and that has potentially caused people to question some of their presentation, their behaviour. Both a little bit speculative, but I think certainly across the work we've been doing in South East London, those two things seem to have contributed to that spike. And I think to Joe's point earlier, you know, there definitely is a primary care factor in terms of our increase in referrals. And this is a place where we've seen that quite a lot, actually. So in the 39% increase to referrals generally into PCP and mental health, actually they're just referrals that we accept. There's a huge amount of work that then goes on that kind of takes a lot of clinicians' time on the referrals that we reject. So what we've seen is a much higher rate of rejected referrals alongside that spike in increase. But with ADHD, the threshold for referring somebody does appear to have lowered. And that is something that's being taken forward with primary care across South East London. So there are some screening tools that are going to be made available to primary care so that they can do some initial screening prior to making the referral. They haven't yet agreed to do it. That's the plan. So we'll see if that kind of helps.
Thanks, Lorraine. So thanks for the really detailed answer.
Nina, please.
I was just going to input some personal experience on this, Andy, and some of you might know that I'm going through ADHD assessment processes for family members and have done an enormous amount of reading and kind of seeking out anecdotal evidence, and everything that Lorraine says is absolutely spot on, but I suspect that there are a large number of children that are being diagnosed with ADHD as a result of the circumstances that we put them through in lockdown and situations that were way harder for ADHD children to be able to absorb. And there is a very strong hereditary connection with ADHD. So if the child is diagnosed, then there are obvious questions for the parents and others in the family to other pathways that open up for those. So I view it as an enormously positive step. And I think it's something that the pandemic has probably helped shine a light on, but that doesn't make our position as a service provider any easier. And for those who are waiting to be assessed, I can confirm that it is an incredibly difficult experience to go through. I am incredibly proud that Oxleas uses the gold standard QB test, which I have been reading a lot about over the last few weeks, and it seems to be a very powerful tool. I think we were one of the early adopters of that, so well done.
Thanks for that, Nina. Well done. Thanks very much indeed. If there's nothing else, Lorraine, thank you very much indeed for that presentation. Rachel, please.
Thanks very much. You have an update in your pack related to building block 8 from the strategy, so related to sustainability. It's somewhat hidden in the strategy behind financial resources, so I might want to argue that next time we review the strategy, it has a section all of its own. But I just wanted to update you now on where we are against our green plan, which we published in January this year. So you may recall that the NHS has set a target of 40% reduction of carbon emissions by 24-25, 80% by 2032, and 100% by 2040. They're hugely challenging targets, and we're obviously in it for the long haul. But there's also a distinction between the carbon emissions that we can directly impact and those that we indirectly impact. And something like 60% of our carbon emissions relate to indirectly created carbon emissions. So that's something we need to work really hard on to make sure that in the later years of this plan, we've got strategies in place to deal with that. But in the early stages, we're looking very much on the things that we directly impact. And the largest proportion of carbon emissions directly are related to the energy usage in our buildings. So that's the thing that we've been focusing on mostly within the estates team. And we've been reviewing, we've done some studies around heat decarbonisation plans on our sites, mainly focusing on the 4 largest sites. To implement the strategies that are developing in relation to that looks as if it will require investment of about 25 million. So there's a real link with the risks that we have around capital investment going forward. But the work we're doing at the moment is to look at how we reduce our demand for utilities before we get to the point of implementing new technologies through things like improved insulation, double glazed windows, fairly low key kind of actions, but things that will bring the the need down before we have to invest in new technologies. We're also looking at things like reducing temperatures in buildings. Sounds very easy, it's not very easy, partly because of our old infrastructure, partly because people feel and experience heat in different ways. And so getting a consistent balance is not always easy. We've done really well around LED lighting. So 80% of our estate already has LED lights, and we're looking to roll out the remaining 20% in the next 2 years. There's a scheme looking at what's called voltage optimization. So that's reducing the voltage that comes in through the national grid before we start using it, and that can reduce our electricity usage by up to 8%. And we're also implementing smart meters across our estate so that we can properly measure and monitor our usage going forward, and that will feed into the KPIs that we're looking to develop in the future. And I think most excitingly for us, we now have Karen Jandy on board, who's our new sustainability manager. She only started in the last 6 weeks, so a lot of the work that she's doing doesn't really feature in this update, and her work will be much more less focused in on estates and much more focused on engaging the rest of the organisation in the work that we need to do. So she'll be revitalising the Sustainability Action Group, working with directorates to support the schemes that they need to take forward within their areas, because it will involve a much broader perspective in terms of how we deliver services, how we procure our services. We need to think about this in all the decisions that we're making across the organisation. So she's looking in a number of different areas, and I'd really welcome if the Trust would like that we do a broader session around this, maybe at one of our development days. She's looking at how she makes those links, making the resources available for teams across the organisation. So she's setting up a Teams channel. She's looking to have a web portal, doing regular sustainability videos so that we can get this in people's minds and in people's thinking. She's got some campaigns planned around, there's something called Do Nation, where you make a personal pledge about what you're going to do as an individual to reduce carbon emissions, but also campaigns across the whole organisation, things like switching off lights, really, again, very basic stuff, the kind of stuff that we all do at home, but people don't do quite so regularly when they're at work. She's looking at rolling out training. So there are a number of different sources for training in sustainability at different levels that she will be rolling out across the organisation. And she's also working with some individual teams who've shown an interest in particular pilots. So things like a waste pilot on Holbrook, and doing some cycle training and putting in additional facilities for people in bridgeways. So some small scale projects which we hope to roll out on a wider scale across the organisation. So I think the challenge for us now is how we make sure that sustainability features in all our decision making. I think as an exec, we've agreed that it will go on our front sheets as a consideration when we're making decisions. I would welcome that going on the board front sheet if people would welcome that. And we will be developing some KPIs so that there's a mechanism to ensure that the work that we're doing is actually delivering the impact that it should. And we're talking with the ICS about that, because the development of KPIs is not necessarily easy. I think you're on mute, Andy. If you...
Yeah, thanks, Rachel. Jo, please.
Yeah, thank you for the paper, Rachel. I thought it was really interesting, actually, and I think we do need to get this out more at all levels. There's a lot to do. A couple of points occurred to me. So certainly in terms of around estates, business cases for doing things like window replacement or other sort of bits of maintenance, which previously were difficult to justify in terms of savings, might now be justifiable because the cost of energy is so high. So, you know, there's some basic stuff around that's probably worth looking at. On some of the bigger or more specialised stuff, how much are we able to work with the ICS, and if we're not, is that something we can influence the ICS? Because if I take something like, I mean, heat decarbonisation or refrigerant gases, everyone is going to be trying to tackle that issue, and I would have thought it would make sense for potentially procurement or advice on that to be at a sort of a broader ICS level rather than each trust trying to kind of reinvent the wheel.
Yeah, I don't disagree, Joe, and I think that there is a network, and it's a network that is saying all the right things in terms of wanting to work together as a system. There are big players in our ICS with many more resources than we have, and they have quite big teams, which at the moment they are saying that they're very happy that we link in with and that we share that experience. I think the issue about the capital has not really, it's been mooted, but it's not really been tackled. So I think certainly in our capital plans, we are proposing to put some of these numbers in so that we're at least flagging it. And I think ours will be a drop in the ocean compared to some others. So it is something that the ICS will need to think about. There are grants become available, generally at quite short notice, that you need to be able to implement very quickly. But I think that's the only way really that this is going to happen, because I don't see how it can come from existing capital resource. As we're shaking her head.
Ezra, please.
I was waiting, but you didn't directly mention it, Rachel. I do think the end part of the report that talks about the commitment to green energy and the fact that actually we're not going to be able to meet that, it's going to be unaffordable, is important for the board to actually recognise. We're not alone in this in the ICS. A number of other trusts have already come out and said they will not be able to comply with this. Just to put it into context, the cost of going to green energy from the existing energy that we're using is double the price. So it is very, very significant in terms of cost. And I think just finally coming back on the capital element, I've been raising this with the capital in the Finance Director Forum, the fact that green energy so far hasn't got something, but this will require, I think, a national response. At the moment, I think that is unlikely to come forward given the fiscal constraints that I think are likely to come in over the course of the next couple of years, but we will continue to do so. And just also reflecting on what Rachel said, I think it is about the grants. The piece of work that estates are doing on this is really important, because what it means is as and when those grants or those opportunities come up, we need to have a costed proposal that's kind of speed ready effectively to go. So I think we may have to invest a bit in making sure that we've got detailed plans that we can actually apply to those grants ASAP. Whereas before we may have said, well, there's unlikely to be any kind of funding and therefore we're not going to do the planning stage. I think the planning stage and making sure those are ready is really important and will give dividends on some of those grant applications.
Thanks, Ezra. Missy, please.
Thanks, Andy. And thanks, Rachel, for the presentation. I just wanted to ask, I mean, I'm pleased to hear that the exec have already talked about sustainability and looking to have it on their front sheet. But I just wanted to know, with Karen employment, she's in effect a team of one, I'm guessing. So what's the support and the resources that she will have to implement this? Because I've seen a similar setup at other trusts, and they've ended up working in silos and therefore become disheartened about the work that they're doing, because they found it incredibly difficult to engage the trust in the work that they want to do. Thanks.
I mean, you're quite right, MC. She's a team of one, but she sits within our team. So in terms of the estate work, I think that will sit within my existing estate structure. And what I would see her role being is actually linking in with the rest of the organisation and getting support from across the rest of the organisation to implement these things. I mean, that's a big ask, given that people have got a lot already on their plates. But the only way that we're going to be able to do it is by engaging everybody. We did have quite an active sustainability action group a little while back. But it kind of fell away because people came up with ideas and they didn't have anyone to support them to take it forward. So we do at least now have her to offer that support and to develop campaign materials to give people the resources to be able to implement some of this within their own areas. But there's a lot to do and a big challenge. And it's more than one person on their own can do.
Well done, Rachel. Well done to you and your team. Thanks very so much. Any more questions? If not, should we have a quick break? Come back at 12:15, please. 12:15, if that's okay with everyone. Thanks very much. Make a start, please. 3, 2, 1. We're back on, and we're on to mortality surveillance reports. Jane.
Thank you very much. The mortality surveillance report for Q1 excuse me, has been to the Executive, the Mortality Surveillance Committee, and to PQAC. And I just wanted to bring to the board's attention a couple of really important highlights. We've been receiving a lot of really valuable learning from the leader reviews, which are the reviews of deaths of people with learning disabilities. And some fantastic work has been going on around both deteriorating patients and end-of-life care for people with learning disabilities. These were showcased at Abbey's Great Out of Hospital Care Conference, so some of you may have seen some of the poster displays, but the deteriorating patients is really from direct learning from the leader reviews, and this is a great initiative where clinicians are being upskilled around both detecting and escalating physical deterioration, but they're also taking this learning forward with local care homes, which is brilliant. The second area that they're really focusing on that we've heard about is their end-of-life care, which is a very difficult time for people with learning disabilities and their families, particularly amplified by some of the communication challenges that some of these people and families experience. So they've been doing a lot of work around trying to make sure they're using the best toolkits, that they're getting the best do not attempt resuscitation conversations going, and they're making sure that they're very cognizant of the Mental Capacity Act. But one of the areas that they're really focusing on is around co-production, around making sure that they're hearing the wishes of people at the end of their lives, and they'd created some fantastic posters which they shared. So we wanted to bring that to the attention of the board. The other area that's very important is just being cognizant of the learning from the mortality reviews of newborn children. We know that the period of neonatal care is a particularly challenging time and has an impact on the life expectancy of children who have suffered problems during pregnancy and during early birth. And it also highlights the importance of being very mindful of some of the factors that we can modify, particularly during the antenatal period and during early years. These, for example, around parental mental health, domestic abuse, and some of the cycles of deprivation and lifestyles. So we reflected on that as part of our mortality committee. I'll stop there and see if anybody's got any questions on any other parts of the report.
Thanks very much, Jane. Any questions for Jane at all? No, thank you. Oh, Jo, please.
Yeah, if I just add a couple of things. So, I mean, you know, as you can tell from the report, the Mortality Committee covers a lot of very interesting areas, often very sad areas as well. Just a couple of things. One of the things that we are not entirely happy with at the moment are delays in getting cause of death. So that's something that there's new sort of medical examiners function being developed, and that's something Tom used to attend on behalf of us, but when our representative is sort of our new representative is sort of decided upon, then that's something we want to push, because whilst there are often genuine reasons why cause of death is delayed, it does hold up our reviews, and it means that we're often holding cases open for quite a long time where, to be honest, we don't think there's too much of an issue, but until we've got cause of death, it's very difficult to close that off. So that's something we want to push. The other thing on LEADER, and it was subsequent to this quarter's work with the Mortality Committee, we got to see the sort of the annual report from LEADER. And this is something I shared at the partnership board, because whilst there is good learning from LEADER, and I'm pretty confident that we are taking that forward. The stark situation is that things haven't really improved since LEADER started. So the gap in age of death is pretty much the same as it was, which is about 20 years. And there are good reasons why there would be a gap, but I don't think anyone can feel that they can justify 20 years. And the level of avoidable deaths, and Lorraine will be on the call, but the percentage of avoidable deaths is very high. I've got the figure of 45% in my head. So We actually discussed that at Partnership Board, because my view is this needs more of an ICS response, a system response. And it was an interesting discussion with all the various things that the ICSs focus on. How can we find time to, for example, at least get that report on the agenda of the ICS board, just to get it in people's minds? Because the leader system it will be a very costly system that has been put in place to address these particular issues. And I know we've had COVID in the middle, and that was, obviously was very negative. But even so, we put that system in place and things have not moved forward. So I just wanted to mention that, and it's something that I am keen to, whilst the natural home of the ICS is to focus on finances and what's coming from the centre, I think we have to see if, there are some things we really need to sort of force onto the agenda. So I just wanted to mention those things.
Thanks, Jo. Anything else on that at all? Was there anything else on mortality, Jane?
No.
Well done, and thank you for that. And still with you, Jane, we'll move on then to the Mental Health Act report.
Thank you. I'd just like to start by saying a great big thank you to Suzanne Schell, who's joined us as the chair of the Mental Health Legislation Oversight Group and taken on the NED role for the mental health legislation. Her enthusiasm and her objectivity have been warmly received by all. So thank you very much, Suzanne. This report has been through the Mental Health Legislation Oversight Group, the Executive, and also PQAC. So I will pick out the key highlights. It will probably be no surprise that there hasn't been a big change in the demographics that are being reported. We've seen a very slight increase in the number of Mental Health Act sections over the last year, and we still see a slight dip in the compliance of Section 132 and Section 58 about information to rights and consent to treatment. The report highlights the great work that the volunteers do, the Mental Health Act managers who are chairing their panels, and they've actually done 196 hearings this year. I know that Suzanne has been meeting with them, and again, they're very grateful for that. So in terms of our demographics, we are still seeing nationally that more males are subject to the Mental Health Act, and more Black and minority ethnic groups are subject, the predominant group being the Black British people. We discussed this at all of the committees mentioned, and we are really aware that the patient and carer race equality framework is being taken forward and will help us to address some of these inequalities and access issues that some groups are experiencing. We also highlighted, I think this has come up earlier in the board meeting, around 13 people who were detained more than 6 times over the year, and these people are undergoing clinical reviews to see if there is anything more that can be done. There are some very complex and complicated presentations behind some of these. So whilst the clinical teams will endeavour to try to find alternative support mechanisms, I think we will have to accept there will be a few number of people that will require an awful lot of support. A couple of things that did come up at the mental health log particularly was the observation around a number of expired detentions. This was really around the Section 2s, where it had been documented on RIA that they were actually under section, but unfortunately they had just expired, or a couple of days previously. This is going to be monitored very closely, and the Mental Health Act Office continue to raise this through the clinical teams, and it's having a very focused piece of work on it. It's going to be reported quarterly to the Mental Health Legislation Oversight Group, and each of the ward will be investigating any expired sections. And the work continues around the Section 132, the Section 58, with increased monitoring and chasing and the development of dashboards. And the business offices are very proactive in following this up, so we will keep an eye on that as well. A couple of areas that we didn't include in the report this year that we will be watching out for next year is around the digitalisation of the Mental Health Act. It's because the plans are going on this year and subsequently that we didn't include it into the report, but we felt it was important to mention here because that's a major transformation that's on the cards. And also the bill is under scrutiny at the moment in regards to changes to the Mental Health Act. I'll stop there and see if there's any questions around the report that anybody has.
Thanks, Jane. Ian, please.
Yeah, thanks, Jane. It is a really interesting report. I didn't have a question. I suppose it was just to kind of re-emphasize some of the things that you've already highlighted. We did have a really good discussion, I think, at PQAC around the contents of the report. I mean, the long-running disparity around overrepresentation of particularly, I think, black males subject to the Mental Health Act was touched upon. We have got strategic focus on service inequalities. We are also an early adopter of the PCREF framework. This has to be a kind of key area of focus, I think. And I think there's so much that sits behind the reasons why there is overrepresentation that I think we have some ideas around, but I think lots and lots of exploration is needed. But I would really like to see some of these indicators that we capture anyway being a kind of focus for that improvement work, really, and with a hope that we can shift. But this is a long-running issue for a lot of mental health trusts, and but I do think we can't duck it any further, really.
Thanks, Ian. Jo, please.
Yeah, I mean, I would absolutely agree with that. The data is so stark, 4 times for sections and I think 10 times overrepresentation for CTOs. I wondered if there's any plan to disaggregate this data and then discuss it at borough level to actually, start. And I guess you have to be careful because there's only so many people represented, and you need to make sure that it is anonymised. But get down with our borough partners and talk about the support available in different areas of the boroughs we work in, because we've got to come up with solutions that work with people well ahead of people getting into the state where they have to be sectioned, I think. So if there isn't a plan to do that, I think it's probably worth looking at, but I suspect there already is.
Nimesi, please.
Thanks, Andy. It was just a comment following on from Jane talking about the Mental Health Act changes that are coming in, and that the fact that the group commented on the significant increase in the burden of our mental health teams and the resources that will be required once these changes come in. The changes are positive for patients in terms of increased advocacy and increased support, but it's onerous for us as an organisation. So I think a bit of work will have to go into how we support that team in order to be able to effectively deliver the changes. Thanks.
Thanks, Nimesi. Just going back to that point on the disproportionality, Ian, where else is this discussed? I mean, I presume these statistics are across the country, maybe even beyond the country, I don't know. But we can't be the only people looking at it. I'm just wondering where else is this discussed, because it crops up, we mention it, and then we move on. And picking up Joe's point about borough, I was thinking about the comments made, the questions at the AMM, from that woman who's talking about what are we doing to help in Woolwich, and I've got no particular answers here, but I just wondered where else, because we're not alone in this, are we? And this is a persistent and consistent issue.
Yeah, no. Absolutely. So myself and Juliana, now she's taken up her role, are connected to a national kind of system around PCREF, and so this is the patient carer race equality framework for mental health. And these statistics are, you're right. I mean, it's a national issue, but obviously I think regionally there is variation, and it's to do with demography. So I think a lot of places are choosing to focus this as a kind of tangible outcome, which you can base a lot of work behind. So you're right, that whole speculation would be that better engagement, not just from Mental Health Trust, but from the wider system with individuals from different communities would affect a different outcome and would reduce this happening. I mean, I think what we can do in mental health is to really start using the kind of platform that the Involve strategy gives us for direct discussion with service users and wider communities within boroughs. Having spoken to some local councillors recently, they're really keen on supporting that kind of direct discussion with different communities. So, for example, in Greenwich, there was a real change earlier in the year in the makeup of the cabinet, and I think some councillors coming in with kind of renewed vigour and energy to support us with this, and highlighting particular communities for us to work with. So I have followed some of that up, and I'm working with Jacqueline and Neil to kind of do more around it. But I mean, that was a really challenging set of conversations, I think, at the AMN. And I think we absolutely have to own our responsibility, but it's not our responsibility alone. Obviously, it's but I think it does lend itself to that kind of place-based structure, because I think it's probably our best opportunity for trying to do something about it, is to anchor it there.
Yeah, I was thinking that, because one can spend a lot of time, a lot of energy, a lot of money, and without necessarily making a difference to this. And sort of having focused and having perhaps some local pilot projects, whatever, where you could say this actually made a difference. I was also thinking about there's the traditional routes of going through communities, but a lot of the young people don't communicate that way. I mean, there are so many platforms that they're involved in. And I was thinking about the success or otherwise of the nudge unit at number 10, thinking about the use of social media, the use of all the different ways that we can communicate with young people, depending what is the message that we're trying to deliver. Anyway, I just thought it would be really worth, I think, having a longer discussion at some other occasion on this, because as I said, this is persistent and consistent all the time, isn't it? It hasn't really changed for quite some time. You've raised it quite rightly, and I think it's incumbent upon us to have a real focus on this, but to capture learning from beyond as well. The only one other point from me was, when you look at that person who had 7 136s, then was it 6 last year before? Just wondering. I'm not looking for an answer now, but the obvious question is, what's the plan, isn't it? If there is such a thing, a plan about someone as clearly in distress, and clearly needing help, but clearly also consuming a huge amount of resource.
Yeah, I mean, just on that point, yeah, it's pretty stark, isn't it? And of course, as you know, as we all know, there have been some national initiatives around repeat kind of 136s, which tried in their way to kind of tackle this, but and I can understand the criticism of them, but yeah, it's incumbent upon us to, as we kind of focus in on those high intensity users of kind of emergency services, and we need to kind of think about what we can do for those individuals. It's not good for them. It can't be good for them, and it's certainly not a good use of public resources either.
Well, thanks very much, Ian. And Jane, thank you very much for those reports, and really good to see you, Jane. Thanks very much indeed. If there's nothing else, I think the other hands have gone down, as far as I can see. Then we'll move on to the committee reports. So it's 12, which is PCRAC, please.
Thanks, Andy. To comment on what you were just talking about in terms of mental health and the detention of certain groups of people, there is work going on amongst what I call the TRI Trust, so ourselves, ELFT and NELFT, and this is one of the areas that we're taking forward, and we're looking at how we can collectively deal with these issues, because all our data is saying exactly the same thing. So we've now got together, and our individual teams are coming together and collectively trying to see how we can share best practice. So I'm happy to keep the board updated on that. In terms of PQAC, a lot of what we've discussed over the last 2 months, we've mentioned at some point or another in today's meeting. So what I just wanted to draw your attention to was the annual reports that we got last month. So we had 5 annual reports, which gave us a fair amount of assurance as to what's going on in the various areas. But still, there were areas that required further scrutiny. So, for example, in terms of infection prevention and control, we wanted to look at it from the prison and forensics point of view, because we felt that that needed extra scrutiny. So that will come back to the committee. Again, as we know, there are pressures across the system, and this is repeated in all the papers that we get. And again, if we focus on our prisons area, Ian's already talked about the inspections that we had recently. So we had good discussions about the areas where we needed to improve, and the areas that we couldn't influence ourselves because they were outside of our control and more to do with the prisons, but how we are working with the governors and with the prisoners to come up with more innovative ideas of how we can provide a good service to the inmates. So those were the main things that I wanted to pick out. Also, I think in terms of the IVR, we had a revamp there. We've been talking about it on this board for a long time as to the refresh, and we were given the progress that has been made so far. It is impressive in terms of the scrutiny that has gone behind the matrix and eliminating ones that weren't fit for purpose or didn't really have a meaning, and inputting others. So I thought that that was a huge development. IT have been instrumental in this and shown us how we could get really granular information, but also really high level information, and then with the analysis at the side of it. So we were assured from that point of view. And then, as you will see, there are 14 exceptions for this month, and we had a really detailed conversation about how we need to push this forward. We know now that we've historically for PQAC for the last year or so, we've had double digits exceptions, and how we get those down. And some of them we're only missing by a small fraction, a small percentage. So it's about focusing on those and clearing them off and getting those exception numbers down. But yeah, that was all I wanted to report back. Thank you. Open to questions.
Yeah, thanks very much, Yemisi. Any questions for anyone at all? Ian, your hands up. Is that an old hand? Yeah.
Sorry, Andrew. Sorry.
That's okay. Yeah, I had a minor point from it was about infection control. I was just conscious when I go around the place, I keep seeing some notices which are out of date, which is around wearing a mask and 2 meters and all the rest of it. And I felt, well, if and when, I hope we don't, but if we go back, if we have to go back to more restrictions, then it won't have much of an impact if they've just been sitting there for a while. I don't know how one does that, whether through Rachel or whatever, but just getting those things down which are inaccurate and getting them taken away, so that if we do go back, they make some impact. Ian, please.
Yeah, it's a good point. We can take that back through the ICC, and you're right about thinking to the future as well. Rates of incidents are going up, and we have got COVID back in our inpatient units at the moment. So it's really important that we are kind of clear what that means for our staff. And some of it is about restating the kind of rules, but you're right, we need to kind of reflect on what's already out there and rationalise it a bit. Thank you.
If there's nothing else for the MSC, thanks very much. Huge amount of work on in all committees, but particularly there. Suzanne's not with us today. We have continuous improvement innovation. Abby, do you have anything to add to the report that's there?
Just to add that what we've been trying to do in the continuous improvement and innovation is to ensure that we are really shoring up our service user and carer participation. So there is a shadow form of the continuous innovation and improvement committee, which is of service users. So we're discussing how to make the material that we look at accessible so that people are able to comment on it. And then we had a very good update from the acute and crisis as to the continuous improvement work they are doing. And we've heard some of that during the meeting today. And we received the quality management report, which brings everything together for the framework in terms of quality assurance, quality control, and quality improvement and quality planning. So that's how we'll be looking at things going forward. But apart from that, got nothing else I want to draw people's attention to, but happy to take any questions.
Thank you, Abby. Sophie, please.
Hello, yeah, just to really add to that, wanted to emphasise from this committee the middle managers article that was discussed on the role that middle managers play in ensuring quality improvement. That's an under-investigated area, and it was one that was really highlighted through this committee. Whether they are the conduits up and down, and without them, it can't really be achieved. So that was a really interesting area of focus. And also we had a great presentation from Jacqueline on involvement, but that also raised questions about how we do map our involvement across the trust, because doing it through a survey, very difficult. We know there's loads of great stuff happening. We keep hearing about it, but it really showed us that it's very, very difficult to actually gather that information. So Jacqueline's doing a great job on trying to do it. But just to highlight that that's the case, we know there's great stuff going on, but we don't know exactly yet how to map everything. So that's a work in progress. So yeah, just wanted to add that.
Okay, thanks very much indeed, Sophie. Anything else on QI? If not, we'll move on to business, please, Jo.
Yes, so there's the comprehensive front sheet covering the areas that we've looked at over the last two meetings. So a lot of which we've already discussed. So rather than pick out particular things, quite happy to take as read and for Azra and I to take any questions.
Any questions at all? Azra, did you want to add anything at all?
So no, I think what Jo has said is we've given a really thorough front sheet that covers off all of the decision making that was taken, everything that was delegated down from the board, and really just that we've had detailed discussions about the interplay of the ICB position on the trust position, which links back to the significant risk that we've got on sustainability, and the one about the in-year risk, just picking it back to the BAP agenda.
Very grateful. Thanks very much. Any questions for Jo or Azra on business?
Can I just ask a question on that, just in terms of board paper length? I mean, we've got quite a comprehensive front sheet, which includes quite a lot of information on the financials. We then include the finance report. Is that helpful to people, or if people don't actually spend any time going through it, we could include that in the for information section? Just
yeah, I think this and other things will come out from the Good Governance Institute report come out, and I think which we're going to discuss, Sally, if I'm correct, at the December away day. Hopefully there'll be some work done before that to see how we can trim these papers right down. Anyway, I think having access to them, Jo, is absolutely right.
Yeah.
But I mean, I take the view that the business committee and the finance department run very well, and I'm going primarily off your front sheet. But, relying on the fact that others will have been through in fine detail the things that sit underneath. Anyway, we can discuss it in detail next month. Thanks for that. If there's nothing else on there, still with you, Joe, on partnerships, please.
Yeah, again, so you can see the update from the group. We had a really good update on where we are in Greenwich. Ian gave us a pretty thorough update on that in terms of partnership working, and I think it's fair to say that we've seen things move ahead in a positive direction over the last 3 to 6 months, which is really good. And clearly understanding how we're working at these local levels is something that we really want to cover at this group. And the other thing we're doing is that we're looking at the different strands of strategy and looking at partnership working. And we had a presentation from Alison about with the various different partners, largely around the SLP and the ICS that we are working with. And I think it's fair to say there was a lot more of that partnership working going on than we might have anticipated, or certainly from a NED point of view. So again, really positive. Other than that, happy to take any questions.
I think that's a good point. You know, every now and again we should highlight what's going on within, particularly I think within the SLP, that's going on beneath board level, because there's clearly a lot of good work going on. So thanks. So any questions on partnership? If not, then thanks very much, and we'll move on to infrastructure, please, Jim.
Thanks, Andy. I'll just bring out some of the interesting points that maybe are not in the front sheet. We did have a very long discussion about the evaluation that came back. It's my fault, I was a bit delayed in it. So we talked about the evaluation report that came back on the committee, and that linked into staff and service user involvement. And two things to bring out about that. We will be bringing in, there was a discussion paper coming that's going to come back to us about that. But to be frank, within some of the work that we do, very much project based, and very much, and within those projects themselves, we do have a lot of staff and end user engagement. So maybe in terms of infrastructure, we need to bring that out more and actually show that at a high level. So that was one point. And then within the estates update itself, an interesting point was that Rachel presented some data on our utilisation in the offices, early stage data, only a couple of offices, but the numbers are quite low at the moment. So that's something that we might have to take forward after Christmas, maybe. But yes, that's a pointer going forward about the utilisation of space and maybe what we need to do next year. We did have a look at the capital projects update, and understanding that we're behind budget at the moment, but we do have projects in place to make sure that we come back on track. An interesting, from a board point of view, would be a forecast of our utility costs. So we had a forecast this year, but they will be going up significantly. I'm sure Azra knows about this. Next year and the year after, but we are looking at something like a 2 million above budget for the next sort of 2 financial years. So that's quite significant, and that's been running through. Interestingly enough, we did have a long discussion about the usage of our electricity and gas. And it does seem to be, although we might be concentrating on heating, it does seem to be electricity is a much larger proportion of our usage than gas. So I think Rachel's going to go back and have a look at that again. We don't really monitor where that goes. So I think in some sense, if we do want to reduce our utility bills, it's more on the electricity side than the gas. We had a really good informatics update from Alison on the digital dashboards that are coming through, and cyber security. Really pleased that we've got our new environmental sustainability officer, which will move that work forward. And I think lastly, we reviewed the capital programme. So happy to take questions.
Thanks, Jim. I don't know if security cropped up. I mean, obviously we've had that circulation about that particular individual who came into Pinewood, and there's other things. And I was just reflecting on that. I know we've discussed it in other forums, but it's making me think not only about Pinewood, but our other places as well. I mean, we want to be welcoming, of course we do, but equally, I just wondered, I don't know, Rachel, any thoughts you might have on it, but whether it's, or you might already be doing it, but whether we have a review of security as far as our front counters are concerned and the vulnerability of our staff. Because even at Pinewood, Yeah, there are times, obviously, when Solomon or whoever is busy, and you can just stroll in. And I'm not saying we should become a fortress, but I just thought, as part of our response to this threat, going to have it or having.
Do you want me to? Shall I answer that?
Yeah, please.
We through the health and safety audits that take place annually, we review everybody's security risk assessment. So every location or team has a security risk assessment, and whilst we're taking individual action in relation to checking around Pinewood, but we are also going back to look at what all the scores are around security risk assessments more generally across the trust. So it's in hand.
Okay, all right, thank you. But perhaps that might be something that crops up through your committee, Jim. Is that the right place for it?
Yes, I think it'll come back through us, and maybe health and safety as well. So I think we'll tell them.
Yeah, Nina's just raised her thumb. Is that I don't want to send it in too many places at once, but otherwise things get discussed twice. But between yourselves, decide where that one crop up will. Thanks so much indeed. If we move on to people, please.
Thanks, Andy. I'm going to keep it brief and just focus on the safe staffing report. And I know that the board has seen an updated version of the document that went to People Committee in September. There was an enormous amount of detail that we covered on this particular report at that meeting. And the key point that we came back to was that this is a report that, in the wake of mid-staffs, was created with the intention of giving assurance about safe staffing, and where there were areas of concern or emerging risks that provided mitigations. And I think over time, and actually looking at it through the lens of, we've been so immersed on COVID for the last 2 years. So I suppose this is the first report that we've looked at as we emerge from the pandemic. That focus seems to have been a little bit lost. And so what of a lot of data that was presented, a lot of very useful data that was presented, the so what, the analysis, was not drawn out in a way that gave us assurance on all aspects of safe staffing. So there was a fuller discussion that was due to take place at the October exec that I understand has now taken place, and the results of which will be shared with People Committee in a couple of weeks. And I think our determination going forward is that, of course, this is a formal reporting requirement and it's an important one and we have to do it. But we also need to remind ourselves of the purpose and ensure that we are providing that assurance, and understanding that it is far from being a perfect tool for all of the reasons that are brought out in the report. So needing to supplement it and support the exec in supplementing it with our professional judgment in instances as well. So I think the discussion that we had got us to the exact place that we need to be going forward, and I'm keen that we maintain that focus. And I just want to thank the exec for the amount of work that's gone into this, I know has gone into this over the last few weeks. I'm happy to take questions on the rest of the report.
Thank you, Nina. Stephen, please.
Yeah, just an observation, really. I thought it was really good that you raised this, Nina, particularly the aspect of the Tarn, with the 40% vacancy rate. And I know the Tarn is a, high acuity, very difficult place, I would say, to work in. So I'm really just emphasising that I think from a board perspective, it's really good that this is this has been pointed out to us, and particularly, as you say, the safe staffing. And the difference over last year. So good that we've seen it and that it registers with us, and you're onto it, and hopefully over time we can deal with it. But I did think it was worrying. Yeah.
Stephen. Rachel, please.
Thanks. So it was a really important discussion we had on safe staffing, and we also then spent 2.5 hours on it last week, and it was a really engaging discussion. I think there is so much in that report. It's taking us a bit of time to work out exactly how we get all of the benefit out of it, and I think we're making really good progress. So I'll be pleased to go back to the People Committee and talk through a lot of that progress at the November meeting. I did just want to highlight, given your points at the beginning, Andy, about what we haven't covered that's in the BAF. There are just two tiny areas that relate to people that I wanted to bring out. One is about us having achieved the London Living Wage status, which is really important in the context of cost of living. And the second is that we've announced the fast track process for our Band 2's healthcare support workers to become Band 3, which means that people who've been enrolled for more than a year will be able for that to happen almost immediately. That will make a really big difference for some of our lowest paid staff. So just didn't want this meeting to happen without that having been brought up in open session. Thanks.
Brilliant. That is really good news, isn't it? No. Jo, please.
Yeah, so less of a people committee comment than a people comment. Given, you know, one of our significant risks, and it impacts everything, is lack of staff and an inability to recruit. I think from all the work that goes on in people committee, I think I'm assured that we are pushing as many buttons as we can locally to do stuff. In terms of, you know, the graduate programme, apprenticeships, etc., etc. I guess what I don't really have a sight on is that, to my mind, is it's improving a position, but there's this fundamental issue out there that there aren't enough occupational therapists, for example. There aren't enough speech and language therapists. There aren't enough specialist medics in some of our areas. There's a shortage of nurses. How much visibility do we have to any central action that is happening and is looking at grabbing hold of those issues and saying structurally we need to do something? I'm conscious that, you know, the age profile of our district nurses, for example, you know, and the issue that we have there. So I guess firstly is, what sight do we have of more sort of structural issues happening to attract more people and to train more people? Is there anything going on? And if there isn't anything going on, how can we use something? Because to my mind, you know, we can do everything we're doing at the moment, but it's not going to fix the issue. Sorry, I'm not articulating that very well. I think it comes from a sense of frustration, I think.
Rachel?
Yeah, I share that frustration, Jo. I mean, when you see the box, when you see on the one hand things like the sheer volume of graduates who are psychology graduates, and then you see that our inability to appoint clinical psychologists, you think, hang on a minute, this is absurd. So I don't feel that I get sufficient visibility of all of that. I suspect that Neil and Jane and Abby might be more closely plugged into what's happening on a profession by profession basis. I do think that the ICS provides more opportunity for us to come. I certainly feel more powerful as one of a member of HR directors across a now much more aligned piece to be raising some of these issues. So I feel as though our platform for raising it is improved. I still don't feel, if I'm honest, I have confidence about how that's all feeding into things that I think are really getting to the root of the problem. But I might not have complete visibility. I recognise that Jane, Abby and Neil might see more than I do.
While others think about that, Nina, please.
We've had this discussion at People Committee, Jo. We've talked about what are our levers that we can realistically influence, and what are those that we need to seek to influence at the national level. And I think that there are various things that are happening, and all of us are kind of aware of the political narrative around this. So I know there are things that are happening. I don't know that it's anywhere near as much as we need it to be. And I think it's almost, I would like to know what more we're doing to highlight the situation that we're in with those individuals that we know from an NHS London and a regional perspective. And I don't know, for example, if we're writing letters as head of people or whatever other capacity it might come in to say, we're really concerned, where's the kind of long-term plan on this? But I think I am assured, very assured by the steps that we're taking and Rachel and team are taking to do things in a really thoughtful, considered way at the level of Oxleas. And the example that Rachel mentioned, which was completely remiss of me to leave out, was the work around Band 2 to Band 3s. We had numerous discussions about this at People Committee, and I'm convinced that the approach that we've taken is a really considered one. And we will continue to do that. but I agree with you. I think we need to have more visibility, we need to ensure there is more visibility centrally of the issues that we're talking about here.
Thanks, Nina. Iffy, please.
Thank you, Andy. Just to add to that discussion, Joe, I don't think you're the only one who's frustrated. I think many of us, as a member of the London People Board, this is talked about all the time. Health education in England are often there. Part of the challenge, of course, is that for many of these posts, it takes quite a while to train people. You know, so a lot of the early discussions are how do you get people on track? But by the time they qualify, be it as doctors, even with the apprenticeship arrangement that's now in place, we're talking about several years down the line. And so we seem to revert all too quickly to international recruitment, to making sure that where there are roles that the few experts we have can cease to do and pass those to others, that happens so that we can concentrate the expertise where it's really needed. And I think that for the next 5 years at least, you know, we're probably going to remain in this position. One of the things that has frustrated me, both at that level, in the London People Board, but also in the South East London People Board, is how terrible we are at workforce planning. You know, our ability to really consider what we're going to need in 5 years or 10 years, you know, and every now and then we get into this position where we're desperate. And I really just can't get it. You know, the NHS seems to really struggle to predict what it's going to need, to plan in good time, you know, and to support various institutions to make sure that they provide the right numbers. So, sorry, I don't have the answers, just to share my frustration. You know, and this was one of the reasons why I joined the People Board in London, that you have people come along and we go over the same story again and again. But so we are plugged in, but there isn't any pearls coming from where we're plugged into.
Thanks, Iffy. Jane, please.
Thank you. I just wanted to share, just before the board, I had a really interesting conversation with Maggie Granger, who's our head of nurse education, and she was giving some feedback on the first cohorts of the Band 2s who have completed their care certificate online and are moving into Band 3 positions. And almost unanimously, it's lit the fire. They have not only not thought that they could become Band 3s, they now see that opportunity to undertake apprenticeships and move into the Band 4s and the Band 5s that they felt were out of reach a few weeks ago. We know that in terms of our workforce, if we can grow our own and retain our local people who are part of our local populations, they stay with Oxleas, and we have lots and lots of fantastic clinicians who, you know, are a testament to that. So although I don't have the strategic plan or the workforce plan, I do have the nuggets that the answers actually lie within our current workforce. And if we can invest in them and really get that upward social mobility and support the apprenticeships and the practice placements, you know, within 2 to 5 years, we could be in a very different position for many of the sort of vacancies that we've got at the moment. And it's not often I come to work and I hear great news before a board meeting that's really sort of made me think, wow, you know, it's staring us in the face. So I hope it's okay to share that, but it felt really good to me, and people are really grateful for this opportunity around the care certificate and to move to Band 3. So thank you, everybody.
Oh, thank you, Jane. That's really good to hear. And practical thoughts, because if we ever wait for central workforce planning, I think we'll be long behind. Rachel, did you want to come back in? Was that an old hand? No. All right. Well done. Thanks ever so much. A really good discussion. Thank you. Audit and risk, please, Stephen.
Thanks, Andy. And just to go back to the partnership for a second, I should have mentioned we were touching on people being kept in over-restrictive conditions, and there was a TV programme about this, wasn't there? I think it was last night, about people being kept in inappropriate, secure environment. And it just reminded me that through the SLP, if you will correct me if I've got these figures wrong, but there's been something like 1,250 assessments carried out. I think it was the first phase of complex care, and something like 250, maybe 300 step downs Certainly through our partnership with the SLP, it has been very valuable, that kind of work that's been carried out. And sort of we reflect quite well compared to maybe to some other organisations. Then on to audit and risk. Yeah, just three things for me to mention. First of all, thanks to Yemisi for coming in to update us on the PQAC register. And apart from what I've written in the report, I think it was also a good reminder from Yemisi about the what's coming over the horizon in respect of prison healthcare and the required resources for that, and the sort of growing risk, which I know we've already recognised in various registers. On the KPMG reports, Directorate Risk Management came out very well, significant assurance with minor opportunities for improvement. And amongst the comments, first of all, how good it was with the Directorate Risks that within the limited time since we changed that structure, you know, that has been caught up very well, and the organisation has done well to sort of adapt to risk identification within that new structure. And they commented on that, KPMG, about our good governance processes, the structures and frameworks, so that came out very well. Patient safety data wasn't quite so good, partial assurance, and KPMG talked about a need for consistent input of data and working at ward and team level. Our general feeling was that we would probably want a re-audit of that, allow for various mitigations and improvements to take place, but sometime in 2023 we would like that re-audited. And then the final thing, which is a good piece of news on the external audit update, a few months ago, back in end of July, the Financial Reporting Council did their annual review, and Grant Thornton came out the best of any of the major accountancy companies. They had 100% record in the top grade that you can get, and good for us, KPMG were the second company actually with 84. Now I hasten to add, these are relatively small samples. I mean, Deloitte's had 17 cases assessed, Pricewaterhouse I think were the most with 18, and in the case of Grant Thornton it was 5, so you could argue that's a relative small sample, but nevertheless you know, the outcome was exceptional. And as I say, the only major accountancy firm for their external audit to get 100% record. So both our auditors came out of it pretty well, but certainly on the external audit front, that was excellent news for Grant Thornton. And I always like to remind us of Azra's comment about how thorough they are, that they crawled all over our paperwork and all over our financial data at every, you know, every annual review, which is always good to hear. That's it from me.
Thank you, Stephen. Any questions for Stephen at all on if not, then health and safety, please.
Thanks, Andy. We had two main topics of discussion at our recent meeting. The first was on an update on assessment actions that were required as a result of the Sharps audits of the last few weeks, on which we noted significant progress had been made. And the one thing that I'm really pleased about as part of this work is that it was broadly identified that the Sharps policy needed to be reviewed to ensure that it was future-proof. So that work is underway and will be presented to the exec for approval. The updated policy will be presented to the exec for approval very shortly, and then will come to the committee at its November meeting. And the purpose of the review of the policy was really to make sure that we're taking an approach that balances the need for health and safety as well as the need to be able to rehabilitate patients consistent with our CQC regulatory responsibilities. The second strand of work that we focused on was the very extensive work that the organisation is doing on violence and aggression. And we had an update on the presentation that we had back in July. And we reminded ourselves that we are a time-limited committee, and we will review the direction in which the committee goes, or more appropriately, the board will review the direction in which the committee goes once we have the next annual health and safety report, which will be which we're aiming to have for about April, May of next year. Happy to take questions.
Yeah, thanks, Nina. I was thinking on the sharps. This has been raised with me in a few places. People are now in rehab or whatever, but trying to get them to the outside world, and that have we been overly restrictive? It's useful to hear this. Anything for anyone else on health and safety?
Andy, the one thing I would just underline, as we did in fact at the meeting in September, was just really an invitation to exec colleagues that if there are other policies like this that we feel were fit for purpose at the point at which they were introduced but are no longer really serving their purpose, I think every member of the board would be very open to revisiting those, because we're not interested in the sake of having policies for the sake of having policies. They do need to meet the requirements of the service directors, as well as more broadly organisationally, obviously.
Yeah, I think that's absolutely right. And I think it covers any aspect of what we do. You know, now and again, you come across someone and say, well, it's trust policy. And you think, well, why? It's been our gift to change these things in the main. Anyway, thanks very much for that. There's nothing else on that. We'll go over to board visits. Looking at the first one that I can see, which was a very thorough one, to Green Parks House. People have got the report. Azra or Alison, do you have anything to add to the report that you've got there?
So I think what I have done is you've got a very thorough write-up of that board visit, which did cover every service for acute and crisis within Green Parks. I'm going to say very, very busy team. A lot of information that then came back to the reset work that we've seen that was highlighted within the overarching report that Ian had presented earlier on in the meeting. I'd say still some work to do, and we're trying to make sure that future board visits aren't quite as jam-packed as the one that we've seen. And I have to say, because Alison has come along to those visits now, there is very often quite a focus on IT and support infrastructure. So I wasn't intending to say anything more than that unless Alison wanted to add anything.
Oh, that's fine. Thanks, Ezra.
I thought it was really, I was impressed by what you covered in that visit, because there's a lot to see, isn't there? So well done on that. Thanks very much. The next one to Greenwich MSK, Joe, please.
Yeah, just to say, I mean, it was a very positive visit. This is the team managed by Holly Laws. You know, we asked the questions about Guardian, you know, the Guardian, and I mean, they were all over it. Sorry, there's noise outside. But yeah, it was very positive. They had lots of ideas, and you can see that our reaction to those ideas was to kind of tell them to push them forward, really. But it was very good.
Oh, well done, thank you. On the Specialist Children's Services, Rachel, please.
Yes, so it's all in the paper. Two brilliant services, music therapy and dietetics, and people there who were put forward for some of the individual awards in recognition of their fantastic management. It's quite tricky, the music therapy funding, because they don't kind of have it in a kind of block way. It all depends on the relationship with the schools. That makes it a bit tricky, but a real potential in that team to do more. And then dietetics, heroic attempts to tackle the backlogs, but two really good teams.
Brilliant, massive. Greenwich PCP, Stephen, please.
Yeah, sorry, this is a short report, this one, because we had a technical problem. I know Lorraine was there face to face, I was joining virtually, so it is one we have to go back to. But this is certainly one of the teams who were very hot about inappropriate referrals from GPs. So I mentioned earlier that we'd heard it from a few teams, and this was certainly one of the areas. Apart from that, a lot of the comments you particularly get in the Greenwich area, the whole thing about mobility, you know, driving and finding parking in various locations being a major issue. But you know, Lorraine and I will be going back to that soon in the new year.
Stephen, the next one you went to, Bromley CMHRES.
Yeah, this is a really good visit. This team, very positive, but what I particularly loved was they were really all over the sort of outcomes and data. I mean, any question I think Lorraine or I asked, they had the answer for with figures to back it up. So really good, full of praise for the graduate scheme. They've got a new graduate on the back of that. And, you know, they were particularly pleased with the sort of increased energy the graduate had bought and was very willing to look at any project they wanted to put them onto. So it was really good. The one thing they could do with is just, and I suppose we get this regularly, is a little bit more space, but they weren't being greedy, shall we say, on that. You know, they were looking for a small room, which would need to take only 3 people. And I think we probably could reconfigure one of the existing rooms to do that. So it was a small little comment in a sense, but I think would make a big difference to them to have that extra meeting space. But as I say, a really, really good meeting.
Thanks very much. On these, in general, I know there are some colleagues who are waiting for this to come through that might have happened reasonably recently. I was just wondering, Sally, whether we need to have another look at these just to make sure that they are getting booked in via the directorates to go ahead, to make sure that we've got a good rhythm of them going into the future. I do think these are absolutely vital. It's and the exec to get out. I appreciate it could be a pressure of time from the exec. You know, I know there's massive pressures on your time, so I'm quite happy to review and reflect on how we do this.
Okay.
I noticed that things have just dried up a wee bit. Some places. Just going back to my visit to the district nurses yesterday, which is not part of this programme, just part of my running around. I know, Iffy, you were out there recently when you were talking to district nurses, as far as I remember. These inappropriate referrals crop up a lot. You know, I know during COVID when we were doing these, it was because there was a COVID problem for primary care, and that we were picking up the blood tests and all the rest of it. But my impression was it hasn't eased off. It hasn't gone back to primary care, and this was a theme from both places I visited yesterday. And not only the pressure from primary care and the difficulty of then going back to them to argue about it, which in itself is time consuming. And then also some hospital referrals, which I thought were wrong, particularly around catheters and TWOC, which I thought meant taken without consent, but it's something to do with people using their catheters at home. Trial without catheter, I think I was told that refers to. And and what I was wondering about is, I know there are the regular meetings, but do they have the ability to elevate these concerns, and where does it go? I mean, going back in time, Ian, we had similar discussions with Bexley CCG, you know, some while ago about inappropriate use of our district nurses in lieu of practice nurses, essentially. I was just thinking it was such a theme, yeah, and I just wondered what we do with that. Ian, please.
Yeah, so I think everybody's aware that in Greenwich and Bexley we have a multi-agency meeting called Resplendent, which started in COVID. So that brings us together with the local authority, LGT, Darrant Valley, the hospice. And essentially that is, the focus of that is to to develop the Home First offer, but tactically respond to situations as they happen. And it is led quite a lot by the hospital. I should say general practice is there as well. But it does afford an opportunity to raise some of those things there. Below that, there is a group that oversees the transfer of patients from LGT out into the community. So there's an opportunity there to look at discharge practice. And I am really kind of pushing for those discussions to, they do look at things through the lens of the acute, but it's an opportunity to kind of reframe things and say, if you want patients to come out to the community, we have to look at what is actually happening out there. So it can pick up on, and it needs to continue to pick up on the quality of those referrals. I think GPs, it's slightly more difficult, but certainly in Bexley, they are reconstituting something that was in place pre-COVID, which is to have case discussions at LCN level. So it brings us together, including district nursing, with GPs. The other thing to say is that I and others are raising this with the place-based directors to make sure that everybody is cited on it. So with the LCPs, they are developing risk registers. I've made the point very clearly that those risk registers have to be aggregated up from individual organisations. And I was pleased to see that at the last Bexley Local Care Partnership Board, where we were talking about this, the place-based director did say, without me having to say anything, district nursing needs to be on here. And, you know, Oxleas has raised this and we need to kind of do something about it. So I think there are kind of mechanisms at a number of levels to address this. The other thing to say is, over and above all of that, I attend something called the Urgent and Emergency Care Board for South East London, which Ben is co-chair of, Ben Travis. And I have said we need to start thinking about the community offer as part of that, because whilst I absolutely get the pressures in the acutes, if you don't attend to the rest of it, we're never going to be in a position to help. So it's an ongoing conversation, and I'm glad you raised it, Andy, because I think a number of us need to use every available opportunity to talk about these things and kind of really flag it up. And I'm sure if you'd want to talk about the community provider network and the role of that in terms of kind of advocating for community services.
Thanks, Ian. Iffy, please.
Absolutely. Ian has kind of given a clear account of all the arrangements we have in place. And I do sometimes worry that although these things are discussed at many of these levels, the real clinicians who are involved in the day-to-day, perhaps don't hear it or don't care and just want to get things done. And it just occurred to me right now whether we ought to revisit the idea of quality alerts that enables us to count how many of these incidents there are. It enables us to push for some feedback at the point where people were either discharged without the necessary equipment in place or without liaising with district nursing, etc. And that's a conversation that I think we need to have with those who are involved, particularly at Resplendent, which is nearer where the action takes place. I mean, certainly when GPs introduced it, I think it helped focus our minds in terms of their experiences. But we've never been good at raising those from our end back to either primary care or our partners.
No, I think that's a really good point. It always seemed to be just raising stuff with us rather than us raising stuff with them. Abby, please.
Thanks, Andy. I think what Iffy's describing is the reverse quality alerts, and they tend to, we have done, and we're increasingly doing them, but they go to the ICS rather than place. So we probably need to have a mechanism of reporting these to place or to the GP Alliance or something, but they go to the ICS rather than to place.
Yeah, that's really helpful. It's just, I thought there was a degree of frustration yesterday that they've raised this a lot. Being sent to people who apparently were housebound and then they weren't, and a whole range of things like that, which we've heard for years actually. But sort of COVID, you could sort of understand it. But they almost see themselves as the catch-all service that does everything that everyone else throws at them. And but as usual, full of energy, full of spirit. But I felt it'd be good to be able to answer them. Anyway, anything else on the board visits? If not, Council of Governors update, you've got it in front of you. Board agenda, just thinking about, before you spoke, Sally, the December one where we will discuss the Good Governance Institute report. I was also thinking partnership. I'm really impressed with the amount of partnership work that's gone on. It really seems to have stepped up. It's probably maybe because you're talking more about it and you're just doing it quietly in the background, but hearing it today at every level, whether ICS, SLP, and locally, it really does seem to have moved on. I think Embassy raised that. And I think well done for all the work that's gone in there. And I don't underestimate the amount of time this must take for you to attend these huge number of meetings. And part of that Good Governance Institute might be around how we can reduce the burden that we're making within Oxleas to see how we can help with it whilst we still discharge our duties. Sally, did you have anything to say on this one?
No, Chair, that's fine.
Okay, all right, fine, thank you. As far as the BAF is concerned, I mean, I don't want to go all the way through it, but have we covered all the points in the significant and the highs?
I've been watching it as we've been going through. The only issue that we haven't talked in depth really is about prone restraint. So that's highlighted in the cover sheet, which shows that it's a PCRAC risk, and noting that there has been a reduction in previous years, but it does remain a high risk that's still under review at PCRAC.
Yeah, I mean, thanks, Ollie. I think you've noted that the number of prone restraints has reduced on this time last year, but we are consistently seeing a number of prone restraints each month. I think the mitigations, though, have kind of really stepped up. So we've got the safety pods in situ, and then also the training to give intramuscular injections in regard to rapid tranquilization and the deltoid. So I think there's a good set of mitigations there, and we are delivering on reducing prone restraints, but I think we would all agree there is more work to do to reduce it further. But as Sally says, we do monitor this at PCRAC.
That's a very good point. Perhaps at our next board meeting, we might highlight that particular item so we can give something. Is there anything else from anybody else? I just want to express my thanks again to our lived experience contributors as part of the film that Neil put out. It was really good to see them on there. And I want to express my thanks to the exec. I think there's just been huge amounts of work. Yeah, it's an enormous amount, and your workload is not going down by any means. And I'm very, very conscious of the demands on you as individuals and as a team. And I think your leadership during this very, very difficult. On behalf of the NES, I say thank you. Times. If there's nothing else or anyone else, review the effectiveness of the meeting. I think it's something which we could do in December as part of our look at how these meetings go. We now have part 2 to move on to. Before I finally close the meeting, look, how long would colleagues like? It's a really open-ended question to lots of people, isn't it? But you've got a short break between the meetings. I've been told I should be giving longer breaks, but I know people have other things to get on with. You know, so if we were to go to 15 minutes, would something like that do? Is that okay? If he says yes, and if he says yes, that's fine. I make that 13:45, being generous. Is that all right? Other than that, fantastic meeting. Really well done, everybody. And now bring the meeting to a close. Thank you.